Procalcitonin is a marker for bacterial infection with a very high signal between no infection and bacterial infection. So it's well known in the diagnosis of lower respiratory tract infection, and in this context specifically to steer the duration of antibiotic therapy. And why do we use it in acute heart failure? Because in acute heart failure we almost have the situation that patients have a congested chest X-ray, they have shortness of breath, and in many cases you're not sure whether this is purely acute heart failure or whether there's also concomitant pulmonary infection. We found in observational studies that once you stratify patients by PCT and relate this with the use of antibiotic therapy, you see that when PCT is low and antibiotics are given in acute heart failure, patients do worse. And these retrospective findings were to be reproduced or to be confirmed by a prospective randomized study. And this was a background for our study, that we tried to prove in a randomized prospective study that the use of PCT would improve outcome in patients presenting with acute heart failure. So the study design is a prospective, randomized, controlled study with an open intervention. And the open intervention is the use of procalcitonin, which is disclosed to the treating physicians in one arm, and the control group had only clinical criteria to do the clinical treatment of the patients and also for the steering of the antibiotic treatment. So no procalcitonin versus procalcitonin in the intervention arm. The findings were a little bit surprising for us because we had no difference between both study arms in the 90 days follow-up with respect to mortality. The study had to be terminated prematurely due to futility after 3/4 of included patients, and after analyzing the 3 months outcome, the Data Safety and Review Committee suggested to stop the study. As we had already included 3/4 of the patients and get on including while the Data Safety and Review Committee were analyzing the data, we had included 762 patients out of 796 planned patients when we stopped. So we stopped pretty close to the end of the inclusion period. But finally, we had no difference in the primary outcome. I think that the concept to use procalcitonin in the assessment of complicated acute heart failure is biologically plausible and still valid. In our study, we had assumed to have an 18% mortality in the control arm, but in fact the mortality was 9% in the whole study. So the study selected maybe the wrong patients, or the study itself improved the use of antibiotics and the clinical care. And we could not show the benefit with respect to mortality because the mortality was already too low. So I think that further studies needed to confirm that this concept is valid in patients with a higher burden of infection, so with higher PCT levels, more frequent pneumonia and so on.